Hello, my name is Leslie Burge, and the topic that we're going to discuss today is end-of-life issues, medical futility, and Texas law. I'd like to take just a few minutes to go around the table and introduce yourself and your occupation and just a little bit about yourself.
My name is Eleanor DeBoer. I am senior at UNT, graduating this summer. It's exciting. My occupation is learning and development consultant, and that's what it is.
My name is Rod Dunham. Hopefully I'll graduate from UNT within the next year and a half. Right now, I don't have a job. I'm retired. So my profession is traveling.
That's a good one. My name is Jimmy Hammett. I'm a sales representative for Rhino Steel Buildings, and I've been doing that for 10 years, and I hope to graduate this fall. And that's a long time goal I've had, and finally get a chance to do it.
My name is Mike Burge. I work for the petrochemical refinery as refinery operator, and been doing it for right at 20 years.
Thank you. Death is a topic that most of us would prefer not to think about, but the fact of the matter is each and every one of us will face it someday, and most of us will have to contend with end-of-life decisions, either for ourselves or for someone that we care about. End-of-life issues have become a hotly debated topic in our nation. There's legislation in every state in the union, but here in Texas we do things just a little bit differently. In Texas, the Advanced Directives Act was created in 1999, and while it gives some of the same information about advanced directives that many of the other states give, it also outlines a procedure that doctors can follow when they disagree with families' choices regarding end-of-life decisions. So how have we come to this point? Well, medical advancements in the last 50 years have brought us improved resuscitation skills with CPR and defibrillation. There's been the invention of breathing apparatuses, ventilators and respirators that can keep people breathing. There's also equipment that's designed for organ support, such as dialysis to support the kidneys, different artificial heart pumps that are on the horizon and are in actual use now, and different heart-lung bypass machines. And we also have better and more reliable methods of providing artificial nutrition and hydration. We can use gastric feeding tubes, we can use central IV lines, and we have better solutions that provide nutrition for humans than we ever have had before. This has created a dilemma. We have all these means of technology that we can use to support people when they're in critical care crisis. Some of those are going to recover, some of those will never recover. So our dilemma is, should we use all available means to ensure life, or should we seek to define quality of life and determine when it's appropriate to use these life-sustaining measures? Different states of illness you may want to consider when we talk about end-of-life decisions. Terminal illness usually is when there's an active and progressive illness for which there's no cure and the prognosis is usually fatal. The term persistent vegetative state has been one of recent controversy. We've seen this with the Terry Schiavo case. But it's defined as a condition of complete unawareness of the self and the environment which persists for longer than a month. And then a term that doctors have coined, medical futility. This is when medical treatment is only going to preserve permanent unconsciousness, and it can't end the dependence on intensive medical care. This means that the person is going to continually require this life support to continue their life. So we have the Texas Health and Safety Code. As I said, this was legislation that was enacted in 1999. And the short title, it can be referred to as the Advanced Directives Act. The first part of the, we're not going to go through the whole thing because it is a 47-page document. We would be here for several hours, maybe even days, debating, every chapter and section of this legislation, but we are going to look at some key areas. The first area what I would like to look at is the definition section. To demonstrate how broad the scope of this law is, it defines a healthcare or treatment decision as referring to the consent, refusal to consent, or withdrawal of any healthcare treatment, service, or procedure that can maintain, diagnose, or treat an individual's physical or mental condition, and it includes decisions even on behalf of a minor. So we're talking about any possible medical treatment, whether it's for diagnosis or actual treatment. We're talking about physical conditions, mental conditions, and we can even apply these laws to any age span from birth to the elderly. Legal instruments that are provided by the law, and these are similar to what other states have enacted, include advanced directives, which is an instruction that a patient gives specific criteria to either administer, withhold, or withdraw certain life-sustaining treatments in the event of a terminal or irreversible condition. And the Texas law includes this broad definition, irreversible condition, without really giving a lot of guidance to which conditions we're talking about. As part of the advanced directives, we also have do not resuscitate orders. These particular forms instruct medical personnel not to perform life-saving CPR or other procedures to restart the heart or breathing once they have ceased. The DNR orders just instruct medical professionals with regard to resuscitation. No other type of treatments are considered. We also have a medical power of attorney, which is a document that a competent adult can designate another person to make decisions on their behalf should they become unable to make these decisions. Chapter 166, Section 39 of the law gives a procedure that a person can, that the law needs to follow when the person has not executed an advanced directive, or if they become incompetent or incapable of communication. In the first case, A here, a person has a designated agent under a medical power of attorney, and the decision-making process goes to both the physician and that designated agent. When there is no legal guardian or an agent under power of attorney, then the physician and, in order of this priority, the patient's spouse, the patient's reasonably available adult children, the patient's parents, and the patient's nearest living relative in that priority would be the decision makers. This is in about 99% of the cases in which end-of-life decisions need to be made. However, most of us understand that we're going to get to make these decisions, but there is a section in the Texas Advanced Directives Act that gives leeway to physicians if they choose to disregard a person's advanced directive. Under this procedure, a physician must have their refusal reviewed by an ethics committee. The physician themselves cannot take part in the ethics committee. They can attend, but they're not allowed to share in any part of the decision-making process. They must provide life-sustaining treatment during the review, and they must assist with the transfer of the patient to another facility and healthcare provider should one be found. The patient and the family have certain rights under Section 46. The patient or family needs to be notified in writing of the hospital's ethics consultation process. They need to be informed no less than 48 hours before any type of review takes place. They need to be given a copy of the statement by the physician of why he's refusing to honor that directive. And they need to be provided with a registry list of the providers agreeing to consider accepting care of the patient. They are entitled to attend the ethics committee, however, they are not permitted to participate in the decision-making process. They need to be given a written explanation regarding the decision of the committee. They need to be given 10 days to arrange transfer to another hospital or healthcare facility before the physician can begin with withdrawing treatment. And under the law, the patient's family is responsible for all costs related to transferring the patient to another facility. Common arguments, those who are in favor of the current legislation argue that we should seek to define a patient's quality of life. Should we allow a person just to go on in a state of suffering just because we have the means to keep them breathing? We should honor a patient's dignity. They say that our current legislation reduces the prolongation of dying. It protects healthcare workers and witnesses and caregivers from the emotional strain of caring from them. That it's humane, that it shortens the grief process for loved ones. That it protects or lessens financial costs and reduces a drain on healthcare resources. And they argue that family and loved ones are not always the most objective when it comes to making these final decisions regarding their family members. Those who are opposed to current legislation, that is the fetal care law or Section 46 of the law, they argue that the doctor's decisions are based on their own personal values regarding quality of life that don't necessarily coincide with their own. Some argue that the law lacks specific language that could lead to abuse. That the 48-hour notification of a review is inadequate to allow families to prepare, either legally or emotionally, for such a review. That the 10-day transfer period is inadequate, that they need to be given more time to find a suitable healthcare solution for their loved one rather than leave them in the hospital that is where the healthcare will be withdrawn. They say that ethics committee selection should be determined by each case rather than having a hospital hand select their own people, that the committee should be composed of greater variability, that the families should be able to have their own religious or spiritual counselors participate in the review process. So in summary, because of the fact that we have had 50 years of advancements in healthcare that have given us the ability to prolong lives of many dying patients, this has created a dilemma. Should a life be prolonged just because we can? Ultimately, the issue comes down to a conflict between a doctor's knowledge and conscience and a patient's autonomy and the family's wishes to honor their wishes. Doctors say that no one can force them to provide life-sustaining treatment that they consider inappropriate, just as patients and families say that they are entitled to having their wishes upheld. As part of our meeting today, we will discuss issues related to Section 46, known informally as the Fetal Care Law. You may consider the facts presented today as well as any previous knowledge, any opinions you have related to end-of-life care. As the result of this discussion, ideas that you have may be forwarded on to legislators to assist them in considering amendments to our current legislation. First of all, do you have any questions about the law as it stands, particularly Section 46?
What is the question at hand about whether the physician can say to pull the plug or not, basically? Is that what it is?
That is correct.
Okay.
Our issue at hand today is families have a right or a patient has a right to form an advanced directive stating their wishes.
Right.
They've laid it out, or we have a process by which we can get information from either the medical power of attorney or a prioritization of decision makers that can say what the patient needs. But this is when a doctor can say, I don't agree with that, we're not going to continue with your wishes.
I'm a little conflicted with that, only because, well, for one, I do think that families should be able to participate in the ethics committee meetings. I think they should be part of the discussion. The other side of that, I also agree that families and loved ones are not always objective. But just to give you an example, my husband's grandmother was in the hospital and everyone was called in because they said she wasn't going to make it through the night. And it's 3 months later and she's still living on her own and, you know, goes to the grocery store and those kind of things. But the doctors at the time were preparing everyone for the fact that she was going to die and kind of pushing his my husband's mom to consider making it so that she wouldn't know resuscitation at the end. So it's kind of a conflict because at the same time, I think families are, unless there's something maybe in writing that the person has these wishes if they're in the state, that families are not always objective when it comes to making those kind of decisions, and you want to entrust the doctor's knowledge as a professional. But who's to say that's always the right decision as well?
Yeah,
This is a tough one.
what kind of time limit do you have from the point of where they get in a particular state of vegetation when that an accident or whatever happens? What's the timeline between there to when you take action? Do you have to wait 3 months, 6 months, 9 months, a year before you say, okay, this has been long enough, I'm the physician now, I'm saying enough's enough? Because, you know, like you said with the grandmother, after a little while, she recovered and she's back to normal. Then you think about is it Terry Shivo, is that correct? With her, she was in that state for a long time, even though I think there was a lot of she wasn't, of course, a productive citizen, but she was alive, and you can tell that. I think they had some bit of she could communicate to a certain degree and make some noises, and there was something there, but how much of that was there, nobody really knew. Nobody could really gauge that. And I think that's a tough issue. It's you know, especially if that's part of your family. If
Right.
that's an aunt or a mom or a sister, that could be pretty difficult. So I think that ultimately that's you know, I'm not sure where I'd stand. As a family member, I would say it would be up to the family to decide, and if this physician in this hospital doesn't want to continue supporting their life, then we would look to seek for alternative facilities to go to. But again, I think another part of it is, as I debate myself here, is that with a hospital, you know, why would they have somebody here? You know, why would they care about supporting somebody's family if, as long as their resources and their bills are getting paid?
I almost think it'd open up another bed for them, so, you know, why wait?
Oh,
When you look at the political aspect of things, you could almost,
They're getting money from the one that's laying there.
That's what I'm saying. I said if they're paid,
It's
if you're paid for it, what's
draining
that?
financially draining the family of their resources. So why can't the family at least go in and pick out a separate individual that has the power of attorney instead of the family having it, which would be another way of getting it out of the hands of the family and also out of the hands of the doctor.
So you're saying that maybe an
An
unbiased
independent counsel.
advocate
Yeah.
might be one way to go. Not necessarily affiliated with the hospital, not necessarily part of one's family or significant others.
Now, I know this, that a lot of hospitals and doctors now require a statement of what you want done,
Right.
whether it's DNR or what. And my own personal opinion is that if something happens to myself and I'm not going to be able to continue any kind of a quality of life, then don't resuscitate. Don't even try. But if it's a condition to where I will have some kind of a quality of life afterwards, like the grandmother, then yeah, I think they should.
So
But
we
at
need
the
to seek
time,
to
you couldn't tell.
qualify what is quality of life.
Well, you know, what about like comas, people who get in a coma?
Yeah.
There's been situations where people stayed in a coma for a long time, and I believe years, as a matter of fact, and then they've come up and they're alive and okay.
Well, as long as, and they have the technology now to monitor brain activity, even if they're in a coma. So if they have the brain activity, then they're still alive. If there's no brain activity, then there's nothing left to do.
So
But if they're in a coma and they're monitoring the brain activity of the person, then yeah, you know that the person is still alive.
But some people can be in a coma, and the only thing you're giving them is nutrition. All you're giving them is basically food and water.
Yeah.
Everything else, they're breathing on their own, heart beating on their own, you know, body functions, I mean, but, so, do you continue giving them food and water?
Well, then that,
Because this states that the doctors can say, no, this, they're gonna be in this state, it's futile, they can withdraw nutrition because it's being done through a feeding tube. So they can withdraw nutrition at that point. If they decide this person's never gonna come out of this coma, then all you have to have is your brain stem. You don't have to have brain activity, you just have to have brain stem. And that can keep your body functions active. But you're pretty well brain dead at that point.
Like I
But
said, if
do
they
you-
can prove that you're actually no brain activity and you're brain dead, why keep the rest of you alive?
So
And I
would you-
think most families will agree, if they're brain dead, they're not coming back.
So would you say that we need to define quality of life, define the conditions for which we would consider either allowing a doctor to come in and withdraw treatment without the family's consent?
I think there should be an independent counsel or guardian or power of attorney to some individual that knows the family, because I personally think the quality of life is up to the individuals,
Not the physicians?
not the physicians. What was their life like? The physician doesn't know. Okay? That's like my dad. He was always active. Okay? And his kidneys failed. Well, they didn't think he was going to survive. And they were debating on whether to put him on dialysis or not. But we came to the conclusion that if he went on dialysis and recovered, then he could still have the not as much of a quality of life or as much movement as what he did before, but he could still have that, even though it might be limited to a point. So by the family deciding that yes, for this individual, by doing this, he can still have a certain amount of the quality of life that he was used to, where a physician cannot determine that, because they don't know the person that well, and I think it's all up to an individual person.
But I think that goes back to too, the family members, you know, what they once were may not be what they are again. And I think the doctors probably know that, based on the medical science aspect of it, to make that determining factor. They may not know them as an individual, but they have the proof based upon their knowledge to say, well, maybe, but probably not. And so
Then that's something that the family's gonna have to discuss, because if the physicians and I think it should be more than one physician that with the opinions, that, like they always say, get a second opinion.
But we're also talking about going through an ethics review.
And I think the family should be part of that. That I do think.
Yeah.
I don't think you should let like all family members go in that, because that could be going back to the circus. That could be craziness. But I think that maybe it is one individual that represents the family and it sits in the ethics. Because I think part of why maybe families, you know, if you don't talk medical language, you have a hard time understanding what's going on. And so having one person who interacts with the doctor specifically and can relay the information back, I do think they should be part of the ethics. And also going back to, I think that the family should also be able to have their own religious or spiritual counselors there as well, if they know that's what the person will want.
Because now, most hospitals and places like that require some kind of a statement stating what that individual wants. Before, even if they just go in for a routine surgery or whatever, they need to state that, so the doctors and nurses in the facility will know. So the individual that's going in is making his own decision there. And I don't think a doctor or anybody else should go against the individual's own decision as to what they want done.
Well, if you have a major accident on the highway,
They're not gonna know.
then, you get taken to the hospital, they're gonna take care of it because it's law, because they've gotta take care of you, but, then you're at that hospital, at that facility, then, they
Yeah, but
may or
then
may not have.
you should
Right.
also have discussed this with your family and particularly your spouse, and let them know what your wishes are.
I agree, but some people, you're just newlywed, I don't think y'all discussed that, have you?
I don't like to talk about that
Yeah.
stuff anyway, so.
Well, I mean, even the law states that it doesn't matter whether you have it or not, if it's the doctor's opinion. And, if one doctor says, it's really not worth taking care of them anymore, okay, it's up to the family to find another hospital or doctor to go to. But once one doctor's already made that decision, how easy is it going to be to find another doctor to say, yeah, I'll take them?
And doctors
When it's
typically
already
don't wanna
been-
override the other
When it's
person's
already
decision.
out there
Yeah.
that this doctor, you're looking because doctors don't want to continue, or is another facility even going to take you? Your ethics committee on this, it doesn't state who it's made up of, it's just ethics committee. Well, it could be made up of business administrator that's looking at the money side for the hospital. I mean, who is the ethics committee? Lawyers?
That's a good point.
Well, you can also look at it this way.
They're looking out for
The
the hospital.
doctor's ethics, if a doctor does not have good ethics on the life, then he may be in it for the money and he doesn't want it done. He wants to keep them there so he can still get the money. Well, hospitals are the same way. It all boils down to that green stuff that everybody wants.
I thank you for your comments today. I think we have come to the conclusion that this is definitely an area of continued conflict, both among one another and even sometimes within ourselves, that potentially there's some room in the law for making some changes, allowing patient representation, maybe adding, as Rod said, maybe adding an unbiased advocate to mediate between patient's family and the physician. So I think there is definitely some room that lawmakers could consider making some changes to this law.
Very good.